Welcome to Webinar Wednesday. We are excited about today's presentation featuring Mark Heston, Director of Clinical Engineering at Children's Hospital, Colorado, Dylan Winthers, Network and Cybersecurity Analyst at HSS, and Ben Stock, Director of Healthcare Product Management at Ordr. They will discuss the combination of products and managed services that allowed Children's Hospital Colorado to cost-effectively discover, protect, and maintain their medical devices in a time of crisis, and how these tools will be imperative to transition back to a compliant and secure biomedical environment as normalcy returns. Webinar Wednesday would like to thank our sponsor, Ordr. Ordr is focused on making connected device security simple through zero-touch agentless deployment, one common platform for multiple stakeholders, and automation of policies to secure devices. With Ordr, you will know exactly what's connected to the network in real time, all the time. With Ordr, visit ordr.net for more information. A few announcements before we get started. Please mark your calendars for our upcoming MD Expo in Dallas, Texas on April 16th and 17th. For more details, visit mdexposhow.com. While you're there, please make sure to sign up for our newsletter so you always have the most up-to-date information. Let's give one lucky attendee the opportunity to win a Webinar Wednesday t-shirt by answering the following question. In what city and state is Ordr's headquarters located? You can find the answer on our sponsor's website, and you can answer by using the questions feature on the webinar dashboard. As always, today's webinar is eligible for one continuing education credit from the ACI. You can obtain your CE certificate by completing the post-webinar survey. More details on this at the end of today's webinar. We will wrap up today's presentation with a live Q&A. You can submit your questions at any time during the webinar by using the questions feature on the webinar dashboard. We will get through as many attendee questions as time allows. As I mentioned earlier, our presenters today are Mark Heston, Dylan Winthers, and Ben Stock. Ben, you may begin whenever you are ready.
Thank you, Jenny. Real quick, bios for our panelists. My name is Benjamin Stock. I'm the Director of Product Management at Ordr. Previously, I worked for SSM Health for over 15 years in the Healthcare Technology Management Department. I've been in clinical engineering for close to 20 years now, and I'm a CBET. Dylan Winthers is the Network and Cybersecurity Analyst at HSS. In his role, he oversees the Spotlight program, which aims to reduce the burden of medical device cybersecurity concerns for healthcare organizations. Dylan has been in the ITIS space for 6 years and has worked at several healthcare facilities, the first of which being a small clinical access hospital in a small Midwest town. He and his family relocated to Denver 2 years ago. Mark Heston is the Enterprise Director of Clinical Engineering for Children's Hospital, Colorado. Mark has over 30 years of healthcare experience and with a diverse skill set, including management of HTM, plant operations, risk management, and many more. Mark is also a CBET and a CHTM, Certified Healthcare Technology Manager, and an experienced professor. Jenny went over the session description, but we will be looking at the different cybersecurity risks within a healthcare environment, the challenges that we are facing with those, and what kind of out-of-the-box thinking we can do to help organizations meet the needs of the ever-changing environment and return to normalcy or establish a new normal, as Mark pointed out to me the other day. Some of the things we'll be talking about and looking into is just the sheer immense problem that we are dealing with in the healthcare environment. The massive amount of different manufacturers, different operating systems and different protocols that are used in communicating with medical devices. Years of technical debt, those 15-year-old MRIs that we're still piecing back together and keeping running on a network that really wasn't built to support them with devices that weren't built with security in mind. Incomplete inventories, knowing what we have, it's the burden of every organization, and it's very difficult at times with all the different means, equipment, and IT assets come into our environment to be sure you have an accurate inventory of what you have. Ownership across multiple organizations and verticals. That's not my problem approach of managing IT security and assets is not acceptable this day and age. IT security is everyone's problem, and it's everyone's responsibility to take control of it. And all the different unique challenges we have with patching medical devices, upgrading medical devices, especially after they're no longer supported by the manufacturer. Purpose-built applications, either by the organization or for the organization, with specific things in mind that have to be accomplished, but security is generally not one of them. And just the sheer volume of devices we have in the facility today to take care of patients. So these are some of the things we're facing today. Malware targeting devices with default passwords. Default passwords have been an issue in the medical field for as long as I can remember. And it is getting better, but it's not getting better at the rate that it should. Manufacturers still restrict the ability to change passwords on some devices that you purchase today, or they make it very difficult to change the default passwords and make it difficult to service the equipment if you do change those passwords. Ransomware attacks are increasing as healthcare has become a large target for these organizations that are our organizations that are built to use ransomware to make money and a profit, and with people who are incentivized to isolate hospitals and have these attacks be profitable for their organizations. Devices, specific that made in China or other areas that are not really allowed by the U.S. government and should probably not be in our health systems either. Ripple 20 was a big one that came around in the last couple of years, and then everyone is familiar with SolarWinds, a vulnerability that no one saw coming, at least that I know of, and that just kind of shook the industry as a whole. On how something like that could happen and the complexities of what did happen. So, Mark, can you explain how your hospital is structured to support medical device needs? Can you explain the structure, some of the positives and negatives that you have experienced with it?
Yeah, sure, absolutely. Thank you for the introduction. And to those that are listening, thank you for joining. One of the advantages is of this type of discussion is that we're not scripted. So please feel free to ask questions, interrupt us. We're not really focused on one quick subject. So I'll give you a little history of Children's. Children's Hospital is, of course, a children's hospital located in Denver, Colorado. It's been around since, I believe, the late 1800s, early 1900s. We're a 600-bed hospital with 3 hospital locations and 17 clinics. We have an installed base, which is unique in that it's only, I'm going to say only, it's about 28,000 devices. But the difference is, and I come from Cleveland Clinic and Thomas Jefferson, which were like at Jefferson, the installed base was 107,000 devices. But the unique challenge here is that we only get very sick patients. We get the sick of the sick. So almost every room that you walk into is an ICU room. And so that's one of our challenges, and how we're structured is really, if there's biomeds listening, which I hope there are, we actually directly report to a senior vice president. And it so happens that senior vice president is also the CIO. So I feel like I've got the best of both. I don't report to the CIO, I report to a senior vice president who is the CIO, so that helps us. The other thing which you'll start to get through this is we have a partnership where we have about 25 techs that half and half are outsourced and the other half are in-house. So we get a nice blending of expertise and support. So that's how we're structured. And I'll push back from there. Ben, did that cover?
Yeah, with your structure, what are some of the positives and some of the negatives that you come in contact with?
Sure. So one of the positives, and I think that's why I'm here today, is that if you look at the software on medical devices and how it's protected, biomed has typically been kind of peripherally on the edge. IT takes it sometimes, biomed takes it sometime, and what we've been able to do is through this partnership is, and if you look at me, I'm a little mature and IT is not my forte, biomed is, we've been able to partner with HSS and with Ordr, and we have one thing I should add, we have a fairly strong IT safety security department that really manages the organization, but they don't manage the biomedical software. So we've been able to start, that's our biggest challenge is we get pinged multiple times a day from across the world. I think most people know, but a lot of people be shocked how many times we get pinged from Korea, China, Russia, Africa. We're trying to get into our medical device networks or into our ultrasounds or into even our IV pumps. So that's one of our biggest challenges, but the biggest thing that the plus that I see is this partnership that we've brought together to where you help me handle that security risk.
Dylan, you're supplementing Children's Hospital Colorado team. How are you doing that, and when should hospitals look at a managed service?
Yeah, it's a great question. How we do that really is we're bringing professionals in to take the weight off of people like Mark's shoulders, right? Again, there are challenges out there. Devices are vulnerable from so many aspects. And again, as we've kind of mentioned several times, right, there's this gap in between biomed, which is much more of a mechanical or a break fix model in that specific department versus the IT or information security department, who are very focused on the network itself, and they kind of point fingers at each other sometimes, right? And so how we can bridge that gap is come in and bring years of experience and a giant complex knowledge base of information on how to go solve those problems. And really, when it comes to a facility taking a look at, how do we manage this problem? How do we consider outsourcing, perhaps taking it internally? There's a lot of factors to consider, right? First and foremost is the people, the personnel, right? The doers that are going to go out and visit room to room to go touch that device specifically. It's the expertise, and as I mentioned, the complex knowledge base that comes with years and years of experience and contact with the manufacturers and the experience of working on medical device, but also the experience of understanding the complexities of cybersecurity, right? The understanding of networking concepts, the understanding of traffic and communication, all of these things kind of bundled together. So when should a facility start to look at supplementing a program? I think that really it comes down to what is their best interest, and that's going to always depend on the varying facilities.
Thank you, Dylan. Mark, we'll go to you with this question. With the lack of resources, specifically staffing, being devoted to medical device security, what can we do to ensure that the resources we have are being used appropriately utilized?
I'll try to answer that question without talking around it, but there's a point I want to make is that as a HTM, I'm not in this business, and I don't want to be in this business. And so I don't want to have folks in my shop that do nothing but software and monitor the market for, there's a new software upgrade for this device, and there's a new software upgrade for this device. And so those are the resources that I would rather put somewhere else and leave this particular item to the experts that follow this. And I'll add one more thing that I should have added to the first part, was that by reporting up through the IT and the CIO, they get how important these patches are, because that's the world they live in. And so they really appreciate and understand that when they come to me and I can say, Heston, if you got this, and I say, yeah, we have this.
Good. Dylan, anything to add to that, how we can make our resources stretch a little further?
You know, here's the trick, right, is everybody's busy. Everybody has a full workload, right? And now when you have the opportunity to, come across a new vulnerability, right, something new every day that's happening, that's just another added weight to your plate, right? And again, especially during COVID times, we're stretched as thin as it comes anyway. So now with the opportunity, again, to provide that supplemental staffing to put that in the hands of the experts, again, that's just a perfect weight off the shoulder.
Sounds good. Mark, with how's COVID impacting Children's Hospital? Being a children's hospital, I'm sure it's unique and it's a little different than most who are working in adult healthcare facilities. What unique things have you seen with COVID?
So with the COVID in the Children's Hospital, it's a little different than what I think a lot of folks experienced in the adult population. The governor came in, and if you look at what the government's done, the COVID has not been focused on children. So the governor came in and took a substantial amount of our ventilators and our beds and took them into the community, and we don't know where they went. We're just starting to get those things back. The other thing that COVID took a hit on was our staffing, making sure that we had to split shift and making sure that things are going okay from a interpersonal, touch points, if you will. The third point was, and I don't have the exact numbers, but also from a reimbursement perspective, which comes back to finances, which we're all responsible for. The COVID folks and the government folks didn't foresee the financial impact that a children's hospital would have by not getting flu cases that we normally get this time of year. For example, our flu cases are down 97% right now. And this is our big season. And so loss of revenue, loss of funding, makes everything a lot more tighter, and they keep coming back. And I know we hear this in healthcare every year and every month, that manage your resources, but the COVID has really reached out financially. And then one of the other things is just getting our equipment back and not knowing where it's been what's going on with the software with it as well. So that's been our fight.
Dylan, do you have anything to add from an HSS standpoint that we've seen different with COVID now than previous years?
Well, again, I think the sharing of resources, Mark hit that perfectly, right? Is we're seeing new products come off the shelf. Manufacturers are struggling to keep up with demand, and again, facilities like Children's are having to kind of share those resources, and we want to make sure, especially when they go out the door, that they are optimized or at their peak performance, because some of those ventilators are going to go save people's lives as well, right? Wherever they go, they're going to be helping a patient and impacting a patient in a lot of ways. So again, we want to make sure that they're going out the door as optimized as possible, and then same thing when the new equipment comes in the door as well.
And Ben, I might add, if I may interrupt just a second, just to give you a better scope, and we have over 6,000 unique devices in that inventory of 28,000, which means there's 6,000 pieces out there that are individual to themselves that this helps us with. So it just gives you a better scope, I feel. Sorry to interrupt.
No problem. In your comment, you mentioned that you have a split shift staff. Was that new with COVID, or was that a process that's been going on for a while? And can you speak to that a little more?
Yeah, so we were not a split shift, and a lot of my peers went to split shift with COVID just to decrease the amount of contact with the shop, because most of the shops are in the basement or don't have a huge area. And so we went to split shifts for a couple of reasons. One was to protect our staff from cross infections, but also we then provided, of course, better service and more efficiencies by being here 24 or 18 hours a day.
So do you feel that's something that's going to carry on even after we work our way through this, or is it something that's going to tail off?
That's a great question. I consider us a mid-sized hospital, not a large hospital. For a large organization, I think you need to run those kinds of things. I think we're on the cusp of need, not need. We're monitoring our own callbacks and those kinds of things. But since we are so acute, I wouldn't be surprised that we do go to this permanently.
With the equipment coming and going like it has, have you been able to use Ordr and the utilization tools to do, to help with that, to identify the devices as they come back, maybe when you're not being told that they're back?
Do people know what Ordr is? Is that?
I guess we could, if you want to maybe go into a brief description of that and how you used it in your organization, it might help.
Yeah, so from a user perspective, and this is what Biomed uses Ordr for. IT security uses it for another function, but Ordr is, for lack of a better word, a security ring around our network, traffic in and out. And I can actually see, and this is what's really cool, especially from a Biomed perspective, anything that pings our network shows up in Ordr. I can tell if ventilators are here. I can tell the last time they pinged the network. I can look at the traffic. And I said I wasn't IT, but I'm not. But you can kind of see the advantages here. You can see who's pinging that thing. One of the things I really like about Ordr, and I'll just use a little example, we were having some interference with some patient monitoring up in a very specific room. And I was concerned we couldn't find anything going on. And I found back and went to that room through Ordr and found out there were some unauthorized devices in that room that were pinging on the network that showed up on Ordr. We removed those devices, issue went away. Now it also talks about software and all those other things, but that's how I utilize it.
Mm-hmm. And you found that helpful with the being adaptive to the unique situations you found yourself in?
Yeah, it's been really, really beneficial. We have had, I can go and see the software upgrades, what versions are on devices, where they're at, when the last time they were used, when they were plugged in, what network, what port. I can gather so much information from that. It's just so useful. It saves you going up and trying to find devices, and we can also tell like the drug libraries where we stand and those kinds of things. So it's been really, really beneficial.
Great. Dylan, I'm going to switch gears a little bit here. HSS offers a service, and you're putting people on site at these facilities, and they're interacting with the medical equipment. Can you talk about the process that you go through to ensure that the owners of the medical equipment, this being Children's Colorado, are kept informed on what's going on and what needs to be done and when it's being done and after it's been done?
Yeah, absolutely. So again, as a part of the program, we're constantly in communication with our points of contact, right? Is making sure that everybody is well established in an understanding of what's going on, right? And so that's going to come in two forms. One, a primary point of contact, right? Someone in Mark's position, either himself, perhaps an IT director as well. We have, again, a couple of primary point of contacts, but also secondary points of contact, right? If we're going to be going into patient rooms, there's a time and a place for that, right? Is making sure that we're reducing patient impact as well when we need to go out and go touch these devices in the field specifically. So for example, a secondary point of contact, if we're working on an MRI machine, for example, might be the director of radiology, right? Where there's a line of communication that we have to establish with them. And if there is an ideal time, perhaps, Thursday afternoons, they don't take MRIs. Whatever the case may be, that sounds like an optimized time for us to go in and take care of the equipment. So again, Ben, back to your point, is it's the communication, right? It's the hand-in-hand collaboration or partnership with our clients and with the facilities like Children's that really make HSS and this program stand out and walk hand-in-hand in a lot of ways.
And Dylan, I'm sure you've had to deal with change control processes at many different facilities. Can you speak to what are some of the better practices you've seen out there and what HSS recommends as far as change control with medical devices?
Yeah, absolutely. Like I said, it's first and foremost is going to start with patient impact. Excuse me. And so if the best time to go touch a device and to make those changes and to make those secure patches, if the best time is 2 a.m., then by 2 a.m. is the best time again. So number one is patient impact, right? And two, again, best practices really come with that communication. And that's also allowing everybody an opportunity to participate, right? So you might submit a change control document and you're trying to get your hands on that particular device 4 hours later. That's not enough time, right? We're all busy. We have things that we need to get done. And so again, it's about coordinating and scheduling. So again, best practices, alert the staff, allow them the opportunity, the voice to speak and be heard, and then again work with the staff and work around the patients to provide that service.
Thank you, Dylan. I'd like to remind everybody this, it is an open forum. If you have questions, please send them in. I can ask questions for the next 30 minutes, but we have a lot of experience here that we're speaking to, and you can get some questions answered that you may have. Mark, coming off of Dylan's question, you mentioned best practices. What are some of the best practices that you guys have put in place around medical device security?
I think this is the #1 best practice, and I actually just took a note because we got for those in the hospital business, we got the infamous call where Joint Commission will be here Monday, right? And guess what I get asked for the last several times is, how are you managing your medical device software and security? And guess who I'm going to pull to the table with me? I think it's a wonderful answer. I think it's a best practice because to me, let me step back. I've managed both in-house programs and external programs that are in-house, if that makes sense, OEM programs. And I have found value in both. Both bring different positives and both bring different negatives. But when you put the both positives together, and I think this is a great example of sharing best practices across the country, this is one of those that I feel really strong about. When the Joint Commission asks me, I'm going to be able to say, we've got this covered and here's the answer, and look at this, we've got the documentation. I think that's a best practice.
Yep. And to piggyback off of that, Mark, again, we're seeing that as well on our side, right? As facilities now are being asked to continue or to make progress on their cybersecurity stance, especially as it relates to medical devices, right? Again, as these devices get more and more evolved and advanced, again, everything's connecting to the internet. I mean, we're seeing refrigerators and beds even, right, is connected to the internet now. So again, to piggyback off of that, those are also vulnerabilities to the network and can be damaging to any facility. And again, as Ben kind of mentioned early in the webinar, unfortunately, the healthcare industry right now is taking a really hard hit in a lot of directions, and that made the industry a primary target for attackers.
I'll add also that even the new freezers, those sub-zero minus 70 million degree freezers, are connected to our backbone. There you go. That's a vulnerability.
Yeah, and Mark, you made a great point there, and we've been dealing with that at Ordr, and I dealt with it at my previous organization. And it likes to bring a question up that I think we don't ask enough, is just because it can, should it? What value does that refrigerator being added to the network, that freezer being added to the network, add to the organization when it can be monitored through another means that is less chance of being attacked, or has a smaller attack vector on it. So our positions and that we're in, we need to push back sometimes when people make decisions that are questionable, and just be, infusion pumps are great to be put on the network. But if you are not using it for a drug, remote drug library updating, or you're pulling that information into your EHR, they're just connected to be a point of attack, and they're not connected to anything that adds value. So when you're bringing those things onto the network, we need to be making sure that they're going on for a good reason, and the value they add is higher than the risk they pose to the organization.
Well, in the old days also loved the medical device infrastructure being separate from the organization. That's gone. It's tied in everywhere now.
Mark, I'm sorry, let's go to Dylan. Dylan, with organizations bringing new equipment in, what role does HSS play in that? Do you start at that point in time, or do you wait until after it's been on the network for a while to get information about it?
Yeah, great question. It's going to start from day one, right? And it's going to start as soon as that device comes in the door. We're going to try and capture that information, and we're going to add it to our list of vulnerabilities and criticalities, right? So again, when you're looking at such a large facility, Children's, for example, right? Again, Mark mentioned thousands and thousands of devices, right? Now it would take a legion of professionals to come in and take care of that overnight, right? So this is a process. And again, I talk a lot about making progress, right? And that's going to start when you want to make progress. What you should ideally be doing first is addressing the most critical, right? And when it comes to the most critical, that can come in two forms. One, the criticality of the vulnerability, right? The damage or the impact it's capable of causing on the infrastructure, but also the criticality of the function of the device, right? We're differing medical devices have different functions, some of which play a much stronger role in patient impact. So how do we combine those two? And with HSS, again, we really put together a roadmap, again, based on those criticalities that says, hey, we need to take care of these top 10 items as fast as possible. What happens next is the next top 10 items. Now, all of a sudden, you talk about bringing in new equipment. New equipment comes in, they're going to get added to the list, right? They're going to get added, and if they shoot straight to the top, they're going to get that attention first.
And Ben, I have one more thing to build upon that a little bit. I think this is also a best practice. Our medical capital acquisition process comes through our department, myself. Before we buy anything, we actually have the process where we send that device over to our security analyst, and they do a whole risk assessment on the company, on the device, and it comes out with, they say it's like a FICO score. Okay, I'm out of my wheelhouse here a little bit, but they come up with like a FICO score that says this device is a 700, you're good to go. This device and company are a 300. We need to talk about this. This is really need to come into this organization. What does it do differently than what the company that's a 700 do? So I think that's a great best practice as well.
Yeah, Mark, you literally took the next question out of my mouth, so I'm a little bit verklempt here on the next question. But you mentioned capital acquisition, and those companies that are coming in at that lower score, the 300 score. Are you just moving to the other vendors, or are you pushing back on them to improve their security and really look at security as part of the device?
We actually are looking, security is part of our decision-making process now. And it depends on the device. This is where it gets kind of gray. We don't have a cut and dry, 600, you're good to go, or you're golden. So the better the score, of course, the more we'll move forward. As you slide down, then we might start looking for alternative products that do the same thing clinically. Again, it goes back to what you guys have been saying, it's all patient-centered. But what's the risk of that device having patient data and balancing it versus the clinical application? It's tough when those two meet.
And Dylan, you've got access to lots of different devices from different manufacturers that you're keeping track of. Over the years, do you think the industry as a whole is doing better with security now and actually focusing on it, or are we just kind of stagnant?
Well, quite frankly, they should be, right? Again, we talk about the evolving medical device. That really puts a strain on the manufacturers as well, right? They don't want to have a product that everybody's review says it's so insecure, and they don't want to make the news either, right? Again, and in a lot of ways, that forces them, that motivates them to make sure that they're tackling this as best as they can. Now, again, granted, there are also thousands and thousands of legacy devices within a network or within a facility. So again, now we have to start looking at some of the benefits to say, if you have a legacy device that's 15 years old, again, we can kind of go back and do that risk analysis and risk assessment to say, okay, this device is now 15 years old and it's posing a risk to the network. When should we start considering replacing that product with something newer, or something more secure, something more advanced that is, again, mitigating in a way the risk of or the potential risk of an incident on the network.
Thank you. And we did have some questions come in. I just had to scroll down.
Hey, Ben, before you go with the questions, one thing we should consider for the ROI on this is how much does it cost in marketplace if you make the paper that has to be published by law because you had a HIPAA violation?
Mm-hmm.
There's the ROI right there.
Yeah, exactly. There's, the average, breach, a data breach, especially in a healthcare facility, gets up into the millions very, very quickly. When you're talking about, again, patient impact, patient information, lawsuits, and again, Mark, to your point, making the paper, it's all about brand in a lot of ways. And so again, companies and facilities, manufacturers, we're all trying to do our best to make sure that that's not a situation we want anybody to be a part of.
Yeah, I can speak personally to this. We you know, when you're sitting across the table from the OCR, and they're asking you for information, you better have it. And you know, when they ask you for your report on all your devices that have PHI and what was done and the risk assessments on the PHI, it better be an in-depth report and be legitimate, or you're going to have problems. We could do a whole hour probably on that subject. So I probably will try to keep that one out a little bit. So this one's for Dylan. How does HSS keep track of software versions for all the different medical devices?
Yeah, that's a great question. And it's going to start by utilizing and leveraging the great tools like Ordr, right? So when you're talking about an individual trying to go and touch thousands of devices, that could take forever. Now, leveraging a tool like Ordr, right now, all of a sudden we have a centralized repository of data that comes to us, and we can export that data and take it back into our program, into our proprietary engine that also houses that particular information. Again, around any type of device whatsoever, right? So again, to Ordr's point as well, just like the Spotlight program, we're 100% agnostic, right? Anything that touches the network at all, Ordr is going to find it. Any type of medical device whatsoever, HSS can address that, right? So again, how do we address that, or how do we keep tabs on that kind of information? Again, it's utilizing and leveraging the great tools like Ordr.
Thank you. This one I think came in for me. Does Ordr utilize RFID tags? So we do not directly utilize RFID tags. We can determine location kind of vaguely based off of access points, and depending on what your network is, if it's a Cisco network and you have Prime, we can narrow that down even closer, kind of like what RFID tags do. We do also integrate with RFID systems. So if you had an AeroScout style system in your hospital and it was relaying back location information, that information can be fed in when you pull the device up inside of Ordr to give you a more exact location. So this question's for Mark. As Biomed HTM, what are you doing because of the pandemic for daily workflow that will be different after the pandemic? So what are you doing now that's different than you think will be in the future once we're kind of through the worst here?
So it's a whole new normal, whatever normal is now. That's awesome. That's an awesome question, and I wish I could really answer it. I will tell you that our workflows have definitely changed. We're not going into near as many patient rooms. We've set up infection stations, disinfection stations right in our shop, right at the workbenches, gloves all the time, 6 feet. We're making sure we've done a whole process analysis of making sure that all dirty equipment doesn't come into the shop. And I think what's nice about that from an HTM perspective is that's finally gotten some teeth. We have fought that for years, don't send that gross thing down without cleaning it. Well, this has really helped with that. The other thing that's been give or take is our response times, quite honestly, have went up, only because we're having the double shifting, so we're running with half the people that we normally do. But they're also taking more precautions before we go into a room or before we even go on a floor, that we're making sure that we're dressed right, that we're appropriate, and that we've talked to the clinician before we've done anything else. So from a pure fix, break, repair, nothing's changed. What's changed is the front end and how we interface with the floors. And at home, by the way, as well, right?
Sorry, at home, yes, definitely. Yeah. It definitely sounds like there's some positives that came out of this, and I think that's something we can all hold on to. You're not the only one I've heard that's gone to a shift style of support, and it was something I pushed for, as an organization for a long time. It was very difficult to staff, unfortunately, because you have to have the right person that one can support a vast amount of equipment on their own, but then also is willing to work the different hours, and that was something we found very difficult to fill in that role, and I think kind of the pandemic kind of forced her hand into that, and I think it's a positive overall for the industry and the service we provide.
And I was going to say, Ben, the other thing we changed was we gave our engineers the option to go into a 4-day work week. And that's been really helpful. Think about it. It reduces the exposure here because they're coming in one listing. Helps with parking, helps with commutes. It helps with a lot of things, but it also expands their workday on site. So it's a lot easier to get somebody to work 4 10s or 3 12s from past experience than it is to work 3 to 11.
Mm-hmm. Yeah, definitely a good point there. And I have seen that in other organizations as well, where the shifts, some people like it, some people don't, but it's got a lot of positives for your personal life, not having to drive, not everyone has the luxury of working from home. When you're a biomed, you have to be there to physically touch the equipment. It's when you're on call, it's hey, can we get them to help us out? And I made the mistake once of asking a nurse if something was plugged in, and I never made that mistake again.
Never, not once. You only do it once.
Yeah, you only do it once.
But everybody does.
Yeah, it was really early in the career, and I regretted it when I walked through the door. I can tell you that much. So, as we look at this, this is kind of the question that everybody asks in these things. And we'll start with Dylan. When you look at everything about the medical devices and the security vulnerabilities, what are some of the big things that keep you up at night that you think are the number one things we need to solve in the industry?
Oh, that's such a great question. What keeps me up at night? Boy, how long do we have? No,
17 minutes.
I think the first and foremost is awareness, right? And anybody on this webinar is already taking the steps to learn more. And I think especially when it comes to medical devices, how do we solve these problems, right? They might have the opportunity, or they might have the awareness to say, hey, these are a risk, but we don't know how to solve them, right? So going out, learning, and finding out more, and how we as the providers and the professionals of what we do, how do we share that knowledge, right? How do we broadcast this to as many people as possible to say, hey, there are fixes out there, there are solutions to these problems that are incredibly impactful, right? Again, not only from a financial standpoint, but again, on patients as well, right? These are the devices that they need, right? And especially in some of which in very critical times. So again, how do we make this a bigger deal, I guess is the very short and simple way to put it.
And Mark, your thoughts?
Yeah, I have a couple thoughts. Biomed has been historically stuck with our legacy thinking that the software is the box and that's good enough. And some things I think we can learn from the IT folks is they've been doing this management for years. And, we get aggravated with them sometimes when they update our office or whatever, but medical devices are there now too. We need to own that and accept that. And one of the clarifications before we end up here is I've talked a lot about technical things and we need to be doing this and we need to be doing that. And the real reason is it's about the patients. I've not mentioned that yet, but really we say this, but it truly is. The last thing I want is a family member to read about their child in the Denver Post. It's just, regardless of the fines, regardless of the repercussions, it's just the right thing to do.
Yeah, my first position was in a children's hospital, and it was, it's a different environment, and just walking down the halls, it's different than being in the many different adult hospitals that I was in over the years. That the children's hospitals do bring that aspect of you are responsible for what goes on, and you need to take that seriously.
Yeah, Ben, I'm
Sure.
sorry. If you think about it, and I know we're cutting short on time, if something gets out, that could affect that person for life, their life and their family. So sometimes we don't look at the scope. So I'm sorry to interrupt, but yeah, thanks.
Oh, no, you're fine. So we've talked a lot about what to do, to help protect these devices. What policies, procedures do you recommend? Do you have that you could speak to about what happens if and a bad event happens, if for some reason your CT was compromised by ransomware? What are you doing to prepare for that type of an event? Mark,
okay. I was hoping that wasn't a question for me, but yeah. So I think we're like most organizations. It's such an acute event that if that happens, it's way beyond me. We're calling in legal, we're calling in marketing, we're calling in all the C-suite, we're calling in the vendors. If it hits outside, it is huge. So we don't drill on it that I know of, but we do talk about it a lot, about that's the kind of publicity that you never want to get. You like your name in the paper, but not this. So we have policies and procedures, and I know we have a drill down on if this happens, but it just, when it does happen, it's just way beyond biomed, way beyond legal. It's an organizational community effect type thing.
Exactly. And to kind of piggyback off of that, right, from a cybersecurity perspective, first and foremost, it comes down to incident response, right? Who's in charge of what? I mean, the fire's up, who has to go and take care of what fire, who's responsible, how are they going to, keep business going, right? I mean, there are patients that are in the other room that might still have functional equipment, right? How do we stick to the continuity of our normal day in life while still addressing something as large and at the corporate or at the facility level, like Mark mentioned, is it's not just one particular person that's going to be responsible for something like this. This is a huge team. This is a huge huge incident that needs to be planned for and as well orchestrated as possible.
Thank you. So we talked about it at the organization level. So let's drill down a little bit more towards the biomed level. Are you doing as far as recovery from an event like that with the increase in ransomware attacks? Has that increased your diligence on backups and making sure that you know where the backups are and what you can do if that event did occur?
So I will speak from past history. I know one of the larger organizations actually went with dual vendors for that specific reason. They picked out for the patient monitoring. They picked out two of the major players. One of the vendors was on site and the other vendor was off site. And the whole thinking behind that was, we've had backup. We've got some measurability here. And that to me was the best practice. They talk about house being standardized. This supports not standardizing everything, so that you do have those kinds of backups already built into the system, so that you're not relying on one model or one vendor.
Yeah, and again, I think that's a great best practice. Again, from a cybersecurity perspective, right? That's retention. That's a data loss prevention policy in action right now. Again, noting perhaps if it's one specific manufacturer or model that goes down, and all you have is that one model, you're kind of up a creek and you don't have a paddle. Right now, you can bring in backups, and you can have, even just from a physical standpoint, you have the equipment available to continue to treat your patients.
I'll interrupt just a second. Here's a great example of that. Living in Denver, if you've seen the news recently, they had the jet engine that blew the cowling off. That particular engine is now grounded. Done. So
that speaks to your point of the multiple vendors, although that does add some complexity to keeping track of the patching
Sure.
and so forth. It's kind of a double-edged sword in the fact that you're providing yourself some protection on this side, but you're also increasing your workload and threat vector on the other side.
Correct.
But I think is probably a good policy if the organization is large enough to support it. So Mark, a little color, since you brought up scope a second ago. How long has it been since you used the scope that's sitting on your desk behind you there?
Oh, takes a tech, right? So I was actually looking at the output of a power supply of a third-party vendor for one of our pumps. Yeah, interesting concepts. I won't go into depth here, but yeah, I can still do it.
We talked really heavily about cybersecurity and stuff like that, but when you get into risk, we had a particular infusion pump vendor that their power supplies had thermal events, they called them, and we called them up and said, hey, your power supplies are catching on fire. And they're like, no, we don't have any records of that. And it went on for about 2 weeks, and then someone mentioned thermal events, and we said, well, how many thermal events have you had? And they're like, well, 3 or 4.
Yeah.
And I'm like, okay, well, that you play with the words all you want, but the thermal event's a fire as far as I'm concerned. If it burned the floor, it's a fire.
Yeah.
So, all right. So I don't have any other questions coming in. So we'll start to wrap up a little bit here. If there are any questions, please get them in quickly here so we can try to answer them the best we can. I'm going to put our contact information. Let me make sure that's showing again up on the screen. If you have any questions for any of us, feel free to email us here. In addition to this, I'll leave this up for another second, but if you are interested in HSS, here's Dylan's contact information. If you're interested in Ordr, we are offering a program for a free lightweight sensor that allows you to test out our product, gain visibility to your devices, see what they're doing. It's very simple. It's fairly unintrusive. You just need a span port on a switch for the area that you want to do it. You can reach out to ordr.net/sensor to sign up for that sensor. I do hope you have some more questions here that we can answer for you. But if not, we can probably start wrapping this up. Jenny, if you have any closing remarks.
Thank you so much, Ben, Dylan, and Mark, for your time today. We had a great presentation, and I hope the audience enjoyed all of your wisdom. I'd like to encourage everyone to visit today's sponsor to learn more about the products and services they provide to our industry. Visit Ordr.net. A quick reminder to our audience that you can obtain your continuing education certificate by completing the post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 continuing education credit from the ACI. You will be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We will be back soon with another webinar. Please visit our website, webinarwednesday.live, for more details and complimentary registration. Thank you all and have a great day.
Thank you.